Yes, so a quick introduction. Good afternoon to you all. Um,
Good afternoon.
Afternoon, we have Dr. Anie, who is the coordinator of the Community Engagement Group, and he's going to talk to us about Sickle Cell Disease Genomic Network of Africa, community engagement and ethical implications. So, Dr. Anie, you have the audience. Thanks.
Right, thank you. So what I thought I'll do in this presentation is just to outline the background in terms of how we, develop the community engagement process, and also in terms of the obviously the implications that some of the ethical issues in terms of doing genomics within the SickleGenAfrica network, and trying to bring these together to bring some understanding of how the core was shaped and developed. So to start with, in terms of the ethical framework, there were three key areas. One is autonomy, the other one is best interest, and then the third area is duty of care. Now, just to expand a little bit, in terms of autonomy is a key ethical consideration for informed consent. And it is actually based on what you call our value systems. So in terms of our societal norms, how we kind of look at how we are autonomous in our decision-making process. And also, autonomy also looks at integrity without coercion. So in any sort of research kind of framework in trying to seek informed consent from participants, we try not to coerce them as either the investigators or those that are involved with the research, so that there is integrity in that process. The second area of best interest is basically in terms of SickleGenAfrica specifically, and also in terms of genomic research broadly, is what you call the return of results. Because as we know, with genomic research, it takes quite a long time from the time that we consent patients to giving them, a feedback of the results. And sometimes because, in this case, we are looking at the risk of, possible complications in terms of sickle cell disease, and also how we present that information. So in the best interest of the patient, we are looking at how we return those results, but with the possibility that there might be harm in terms of the information that we give them potentially. I mean, the example is basically that if you say to somebody who has sickle cell, is that because of the genomics that we've done, it is likely that they might develop, in this case, we are looking at either acute chest or some problems with the heart, for which there is no treatment. Then it means that giving them that information might actually cause distress, emotionally or psychologically. So we have to sort of try and address that in terms of their best interest. And then obviously there are issues around confidentiality, and also, as we know, in terms of data sharing. And as I proceed with the presentation and what we talked about in the focus groups, you get some examples of these key areas. The other area that I thought was very important was duty of care, because a lot of patients do ask that if we do participate in research, for example, how do we also get the government and other people making health policies to address our healthcare needs? And in this case, addressing healthcare needs and their emotional well-being in terms of obviously trying to address best interest and the issue about providing them information that might cause them some sort of emotional distress or psychological issues. Okay, so then the key objectives basically for the community engagement core is utilizing what we refer to as qualitative research methodology, which is basically trying to get qualitative information from participants without necessarily getting a whole bunch, huge numbers of them. And that's why we tend to use the focus group approach, and in this case, using focus groups with key stakeholders in trying to address this. The second area is obviously trying to get further information, and that is where quantitative research tends to apply, and looking at surveys of broader numbers of participants. And in this case, trying to address some of the key ethical issues again, but then looking at, in terms of duty of care, for example, some of the barriers to patient recruitment, and then also trying to look at patient satisfaction at the end of the research project. So in applying these two key ways of doing research, in some way we are hoping to cover the main objectives. And so starting from the first year of the project, which was last year from the launch, going into the second year, and then the final year, that's our plan, to have focus groups along the way, and also do surveys in these key areas along the way. But I think the important thing is that as the project develops, I suspect that we might have to, in a way, adapt the way we address these objectives as the years go by, because there might be need for further involvement of participants and other stakeholders. As we know, our study sites, I'm not going to elaborate. If you can't tell from the maps where we are doing the study, then I think you need to learn your geography. So in the first year, focusing on the focus group as a core team, this has changed a little bit since then. I was central to this, but also had a colleague from University of Ghana, as well as the Kolebu Teaching Hospital Sickle Cell Clinic, Miriam Poma, and then working across the 3 sites. As you can see, it was mainly the site coordinators and the appointed community liaison people. So every site had the site coordinator as the lead, and the community liaison people were, appointed mostly from either patient groups or those who were representing patients or families from that sort of approach. And then looking at the aim specifically for the focus groups, one area that I thought was important is trying to address the concept of health literacy. And that is basically to provide lay information about genes and sickle cell disease. And we did this by demonstrating using beads and other things to try and let those who were not necessarily understanding, because the focus groups were kind of like a mixed group, and there were some lay people who were not necessarily patients, so didn't necessarily understand much about sickle cell disease, but also trying to use ways in which we can explain how genes interact, and also how it affects people with sickle cell disease. And then more into more detail, we look to explore specific issues. And from basically the ethical framework, we look to address areas of autonomy, looking at genomics and sickle cell disease. And as we talked about earlier, the return of results, informational harm potentially, looking at the biorepository, what it means, data sharing, and also trying to address the health care provision in terms of sickle cell disease. And I think that's where we had a lot of sort of discussion and debates, because we managed to get the health policy makers on the spot for the patients to really interrogate them. At the beginning, some people thought that this might not work, but in the end, we all realized that that was the most effective bit of the focus groups. And so looking at the procedures, we invited 20 key participants at each site. We allowed participants to speak in the preferred language with translators. So, for example, in Dar es Salaam, we mainly conducted a focus group in Swahili, and I was the one who needed a translation because in order to allow the group to flow, but for some reason I managed to pick up some of the key points and had translation at the right points to make it work very appropriately. But in other places, people were allowed, like in Kumasi and in Kano, for example, they chose to speak in their local languages more than in English. That really did work. We also had audio recordings of the discussions, which were later translated, for which I'm going to present some of the initial data. You may have seen this slide already, but just to highlight, in terms of the 20 key targeted participants, it was a mixture of parents and caregivers, adults with sickle cell disease, patient association support group members, community leaders, doctors, hospital nurses, community health workers, government health representatives, and as I said, those were very key to this process, and making up a total of 20. And in most sites, I think we managed to achieve a reasonable proportion of the targeted number to make it a very fruitful process in terms of the focus group workshops. So now looking at some of the results, firstly, you can see autonomy in terms of decision making. There were three main categories that came up, and looking at the categories, starting with the personal ones, I've just chosen some of the key descriptions from the transcripts, which is basically taking personal decisions. People would decide and then inform their husband or their spouse. Experience in terms of the condition alone, that is from the point of view of the affected person. That's why they chose to take the decision personally and no reason to consult others. And this is about taking decisions or decision makings about participation in research specifically. So some of the quotes that the patients had to say was, for example, in Dar es Salaam, this was directly that the decision is mine only. Another one is that I usually used to decide on my own if I want to participate in the research or not. That is referred to research generally. This was a quote from participants in Kano. And then family is another area where, in terms of decision making, this is a family decision. So some would say, for example, that they consent if the husband agrees or the spouse agrees. The family decides and supports, and in some cases, a sibling. So decides with a sibling and a sister, for example, and then they use this term gatekeeper. So somebody who is like the gatekeeper in the family, that is a significant person in which who stands in the family would determine that. And a quote as an example was that definitely you have to discuss with your mother or your father. We normally apply the communal way of living. This is from a participant in Accra. The third category is what you call significant others. So spiritual consultation is basically consulting with a religious leader, like a priest or an imam or somebody like that, reverend minister, those kind of people. They would also consult with community leaders, for example, people who have a significant standing within the community. and then who were not necessarily, obviously religious leaders. And in some cases, some were also talking about seeking expert advice. So the opinion of, for example, doctors. These are doctors who may not necessarily be involved in the research, because otherwise there would be a conflict of interest or coercion. But I also believe that sometimes patients actually, regardless of who is consenting them, might actually ask their doctor whether they should participate in the research or not. I tend to get that quite a lot. That when you have a research nurse or a research coordinator or somebody consenting the patient, when they actually see you, they also ask, "What do you think? Should I participate in this research or not?" And in order not to be biased, we tend to try not to coerce them into doing it. But apart from that, they would also, maybe if they know of a doctor who is not necessarily in the same hospital or in the same clinic, as a friend or a family person, they might seek their opinion as an expert. And an example of that is that there is no way that a research of any kind can be done without the go-ahead from community leaders. And that was a quote from a participant in Abuja. Okay, so moving on to genomics and sickle cell disease. Again, trying to look at the area of health literacy that came up in the discussion a little bit. And people talked about explaining in simple language, and this could be in terms of even in terms of translation, you have to make the information as simple as it is, and then detailed explanation is also needed. So even though it has to be in simple language, it has to be much detailed so that they can understand. And an example of the quote is that it is good for us to know that doctors need to give out every detailed information so that as parents, we will know what to do with the children. And this was from a participant in Kumasi. And then going on to return of results and the potential for informational harm, it's about some of the key themes that came out was about knowing chances, knowing the outcome, no matter what. That's what some of the participants said. It's better to be aware of potential complications and prevent them, and also having hope for treatment in the future, even though it's not available at the time that maybe you were informing them about the results of the study. And this quotation was actually quite interesting because a participant in Dar es Salaam said, I can be told that counseling is very important. And this should be given to the community that you have a problem and still live many years. Basically, it's about, having a complication of sickle cell disease, but for which you can live many years. But giving that information without any possible treatment until the future, some counseling has to be offered in terms of giving that emotional support. Another quotation from a participant in Lagos: if there are any problems or risk or complications that a research like genetics will actually predict, the first thing that I would like to do is prepare my mind. Of course, we will all plead to God that such a thing should be dissuaded or it shouldn't happen. Anyway, so it just shows that people are prepared to receive results, but some sort of emotional, psychological preparation or support has to be available, especially if you are reporting to patients that maybe they have a risk of some complication in terms of their sickle cell disease. They want to know, they want to prepare, but we need to give them some sort of support. If the appropriate treatment is obviously not available at the time, and this is, the sort of reasons why, in terms of genomics, people tend to focus on how results are provided to participants. Anyway, then moving on to the next area in terms of data sharing and the biorepository. There were some concerns, although there was a general consensus that data sharing could be a useful thing. There were some concerns in terms of sample identification, that is, linking back samples to the participants. Some had some concerns also about the de-identification of samples in terms of giving some autonomy. And we had to try and address that. Another key area was to do with confidentiality, which is the same thing linked to identification of samples and anonymous samples and so on. And even some were talking about the use of pseudonyms, that is like aliases, maybe as an example. And just a couple of quotes taken out of there. One says, "I agree only if the data will be shared to advance discovery only in sickle cell disease. In other words, they don't want to share their data with heart disease." So one of the questions that we asked in terms of data sharing, we tried to establish where people had some concerns about data sharing, was whether they are willing for data to be shared within only people participating in sickle cell research, or whether it could be shared more broadly in terms of anybody participating in genomic research. So this quote was in relation to that there was some preference for data to be shared with only people doing research in sickle cell disease. It wasn't a consensus. It was, some concerns that were shown, or some issues that were addressed by a small number of people, but that quote sort of highlights the issue. Another quote is that, "I think it is okay, but as long as I have that assurance that my personal information will not be used in future for anything. If I have that assurance, that is okay, and no concerns." So on the whole, I think data sharing is okay for the majority of people, I would say, but making sure that the data or the personal information doesn't get away. And then going to the biorepository, I don't know, there was some debates about in terms of DNA storage, whether samples would go missing and had to be retaken. There were some concerns about human errors, that is, maybe some error in terms of the storage, and also some broad issues around quality control. They gave a lot of examples, but just to highlight a few, there seemed to be, because the biorepository for SickleGenAfrica is based in Abuja, it came out that the participants, either in Abuja or in Lagos or in Nigeria, there was this issue about power supply. I mean, they talked quite a lot about it in some of these focus group discussions. So one example says, "I am just curious, in Nigeria with our collective power supply, how do we really ensure that these samples are preserved properly?" That is obviously over a long period of time, and we had to explain how it works in terms of the repository. And another quote from Kumasi was that it would help in terms of sample storage, but if we store some blood somewhere and then in future more research will be done on it, I don't have a problem with that. And that is basically in terms of the long-term storage in the biorepository. And so now, just looking at some examples of duty of care, I mean, in the focus groups where there was the opportunity for the healthcare policy makers to spend quite a bit of time discussing this, there was just so much, and I just summarized quite a few key areas in terms of things like inadequate resources, inadequate qualified staff, attending to emergencies, infrastructure, socioeconomic concerns, complications, poor health provider behavior. I think it's just attitudes in terms of healthcare providers, doctors and nurses, whatever. Stigma and misconceptions were some of the areas. So some of the examples are, well, the government itself has to do a lot more about provision of drugs in Accra to train more people, because there are not a lot of physicians. And then, if you go to places like villages, no physicians, you only see community health extension workers, common in Nigeria and other parts of Africa as well. In terms of Ghana, we have something similar. And then also looking at when it comes to the issue of funds. The issue of funds is that basically they are turning away patients with sickle cell because they don't have enough money, and this was to do with unavailability of beds, and then all of a sudden it becomes available, and because the sickle cell patients don't have the funds, they are turned away from the hospital. And in this case, also a doctor's attitude in trying to say that they are the experts, and the patient just basically has to keep quiet. And so when they are trying to explain the problems that they have, they get sort of rebuffed by the doctor. Something's happened. Yeah, so that is basically the focus groups. Now, just looking briefly at the first year survey, so that led us to develop our first questionnaire, which has been piloted, but some of the sites have gone on to keep working on it. We are targeting 100 participants per site. This might be lower in some sites than others. Some sites might actually go for more than 100. But as you all know, the more we get in terms of questionnaires from a survey, the more sort of data we collect, the more information we gather, and the better the outcomes. So this year one survey, which we are hoping to complete by August of this year, because it will be the anniversary of the recruitment date. We are trying to address a bit more of the autonomy and decision making, and looking at a few other areas in terms of best interest, return of results, and risk of sickle cell complications. So basically, we want to validate by extending the information that we gathered from the focus groups by doing these surveys to try and extend the number of participants. Okay, so I would just like to acknowledge at this stage that we actually lost one of our community liaison representatives, Henry Wokobia, in Lagos, just earlier this year, but also to acknowledge all the participants and the patient groups who made the focus groups and everything possible, and obviously the SickleGenAfrica staff and all the collaborators. Thank you. If there are any questions, I'm happy to take them.
Thank you very much, Dr. Anie. I'll set the ball rolling with one question. So how would you distinguish between coercion and desperation for care in terms of the duty of care?
Okay, so coercion in this case is related to participation for the research, which is basically that sometimes when we are, I don't think in terms of SickleGenAfrica it might be a major problem, but sometimes when we are doing other types of research where we're actually offering some sort of treatment, if the patient is desperate for treatment, then we are likely to fall into this area of coercion, because we are trying to coerce them into participating so that they can get treatment for free, for example. But in terms of SickleGenAfrica, even though I don't think it's a major problem, we just need to be conscious that as we get to the latter stages of recruitment, because at the beginning there's a lot of enthusiasm, it's easy to recruit patients, but as we get to the latter stages where we need more numbers, the enthusiasm of patients might decline. And as either their physicians, their doctors, their nurses, or people that we know in terms of the research staff that are doing the recruitment, we need to be cautious about not trying to, in a way, force them to participate because maybe their healthcare needs might be compromised. And that is one of the key ethical principles that we need to abide. Because I remember somebody saying in one of the focus groups that sometimes coercion is very subtle. And so I think we need to be cautious, and then we need to be, looking after their best interest as opposed to necessarily recruitment targets.
Thank you. Do you have any further questions?
Luzzato from Dar es Salaam. Can I ask a question?
Yes.
Yes.
Hello.
Well, first of all, I enjoyed very much your talk. Secondly, I think SickleGenAfrica is showing by facts how important its role is. And in that respect, my question is, do you know how many therapeutic trials are currently ongoing in Africa in sickle cell?
I wouldn't know. But what I know is that a lot of the large pharmaceutical companies such as Novartis, Pfizer, and AstraZeneca, who in the past did not necessarily look at Africa in terms of trials, are now looking. A few trials that I have been involved in recent years are all including participants in Africa, but I can't give you a definitive answer.
Thank you. Thank you. The reason I was asking this question is because maybe it would be a very good thing if SickleGenAfrica had such a database or inventory, especially since some new agents are on the horizon.
Yes.
And I think you're doing you collectively, I mean, SPARCO and SickleGenAfrica, doing a terrific job in terms of recruiting to database and newborn screening. But in terms of therapeutic trials, I think we need to be perhaps, I don't know, it's a question again, should we be a little more proactive? Because I'm a little bit concerned that now you have shown by your talk that you're very well equipped to deal with the potential issues. But now let's jump the gun and try to do it.
Yes, I agree.
Okay.
I agree.
Thank you. Thank you. Thank you.
And thank you all for coming. Thank you very much, Dr. Anie, for the very insightful presentation.
Right. Thank you.
Asante sana.
Thank you, Kofi. Excellently done well. Thank you, Kofi.
Thank you, Mahmoud.
Well done.
Bye then.